Hi, I'm Dr. Maile Karris, and welcome to Conversations in HIV. Joining me in the studio is Dr. Antonio Urbina, and joining me from Chicago is Dr. Greg Huhn. And we're going to be having some conversations about some of our more complex patients. The first patient is one of mine, and she is a woman who has been living with long-term HIV since 1994. She has multiple chronic coexisting conditions, including chronic pain, COPD, idiopathic intracranial hypertension, which is an atypical one I know, and sleep apnea. And she's on very stable antiretroviral therapy. So let's start by hearing a little bit of her story.
Tell me, how were your interactions with your healthcare provider or providers during the time that followed your diagnosis? What was it like?
During the beginning, I was terrified. I was really terrified. I didn't know what to expect. With having HIV and taking the medication, I've never had counseling concerning my diagnosis. I had other health concerns. When I was first diagnosed, I was still going through mental stress from almost losing my kids in a major car accident. I still have like a lot of hang-ups about my diagnosis. I think, I feel that's because my family doesn't associate with me because of my diagnosis.
So it's a lot.
Yeah, that is a lot. Yeah.
What do you think? Someone like this comes into your office and is communicating these things with you. What are you thinking? What's your approach? What would you want to explore?
Yeah. No, I think it's a really, really difficult case. I mean, what I kind of sense just from her is just a lot of issues in her life personally, family. I'm always concerned about trust too, or mistrust, with patients and what their perception is about us. And then I just feel a lot of kind of like stigma, right? Just with her family and kind of like disclosure, and that kind of now living with HIV is just this extra burden in her life. And I feel bad for her situation. And I would kind of want to connect with her in any way possible first, and just make her feel that, I'm someone that she could trust and that we're going to go through this together.
Yeah, no, I agree. I think, this person-centered approach. Now in our world of healthcare, we have all these algorithms and we have all these tasks that we need to complete for a lot of our patients.
Yeah.
But we can't even get there, if we're not connecting with them and meeting them where they're at. And for me, listening to her say this story was a little surprising, even though I've known her for a while.
Right.
It's been 30 years. She's been living with this for 30 years, and you can just continually hear the pain still in her voice as she's talking about, what it was like when she was first diagnosed. So she's actually here to see me for several things. She's complaining of some just vague, crampy stomach pains. She's unable to sleep, and this has actually been a very chronic problem. Sleep has always been a major issue for her. But lately, her issue is that she's in an apartment by herself, and she is hearing sounds, and she kind of is getting stressed that maybe somebody's around that she doesn't know is there. And then she said, I just feel stuck. I feel stuck is what she keeps saying. So she's on a pretty stable regimen on dolutegravir, 3-TC, and abacavir, and she's been on this since 2015. And as long as she takes it, she's undetectable. She has taken breaks where she just feels overwhelmed and just needs to take a break, and then she'll get a little detectable, but she's never had a significant drop in her T cells. So she's been immunologically stable, essentially, for many, many years. What do you think about these complaints? How would you explore this? What would you do?
Right. I mean, I think you kind of have to explore kind of what's the etiology of these kind of GI symptoms. Are there any alarm symptoms? So kind of like weight loss, bleeding, GI bleeding, anemia, and things like that. I think I'm assuming that there was, a GI workup here done.
Yeah.
I think for sleep, I mean, sleep is such a difficult one to work up. I think you did say that she did have a history of sleep apnea.
Yes. Yeah.
Is her BMI elevated? Is she overweight?
She is.
She
Yeah.
is overweight.
She
yeah.
is overweight.
Yeah. And did you send her for a sleep study or?
She's a sleep study, but she doesn't like using the CPAP machine because it makes noise and it feels uncomfortable. So she does not routinely use it.
Yeah, yeah. I think we have to kind of just like prioritize the issues here. What's kind of the most bothersome issue that you think she has? Do you think it's her sleep or you think it's her GI issues?
Yeah. Well, so I think it really is more of a manifestation of a lot of symptoms that are chronic and not really getting better. And we're going to get into that in a little bit. But let's hear a little bit more from her.
Sure.
And how are all these things, that you're experiencing affecting your day-to-day activities?
I just been staying in bed. I can't do too much. I get tired. For a while I had some energy, but lately I just been tired. Get tired real quick and dizzy. I'm back at dizzy again, and I can't do nothing. I'm waking up not feeling rested, like I'm tired now.
What other things in your life that are not necessarily a medical problem are affecting you right now?
Not having enough food. Right now, I don't have enough water. And then I'm stressed out, because my health care was really bothering me is my health care right now. I don't know where to go for my health care. I don't know what I'm gonna do about my health care.
Okay, so a little bit more backstory for what she's saying there. So here she's, complaining of a lot of stresses in her life, but when she's talking about, I don't know where to go for my health care, she has had some negative interactions with some of our non-HIV providers. So, within the HIV clinic, she feels safe and she feels like she has a medical home. But because of these other complaints and conditions and needing to rule out some, potentially serious medical conditions, we have referred her to different places, including, medical specialty and some surgical specialties. And she's had perceived a lot of discrimination in her minds and just kind of feeling it, at the end of the day. And this has been something that has happened not just with one provider, but with multiple providers really over her lifespan, or her health span, I guess I should say. So she's struggling now because she doesn't necessarily want to leave our clinic. She feels comfortable there, but she feels that she cannot continue to see specialists within our space because of these interactions that she's had. And that kind of brings me to one of the first things that I was wanting to discuss, the impact of race, gender, and other minority experiences on the healthcare experience. So, we do know that statistically, non-Hispanic Black women have a lower life expectancy, higher mortality in maternal and infant mortality rates than non-Hispanic white women. We know that for a fact. And we know a lot of that has to do with historical racism within medicine and other practices. But because of that, Black women and other minorities experience lots of not just actual discrimination in the healthcare field, but they, because of these past experiences, begin to perceive or anticipate having discrimination.
Right.
And those negative experiences have really then drive them away from re-engaging in healthcare or engaging in healthcare to start. So there was a really nice study done in the HIV community, and this was specifically focused on people who were using drugs, and looking at, okay, what is it that we need to change in order to help people who use drugs get into HIV care and stay in HIV care and ultimately have an undetectable viral load and be healthy, at least from that standpoint. And it really is all of these different things. It's these experiences of discrimination, the perception that they will be discriminated and not wanting to go through that again, as they perceive it relates to their HIV status, their race, their gender identity, and so many other things. So I think it is important for us, and I don't think all HIV doctors get this right. I think we really need to also think about our own implicit biases that we have towards different minority groups and try to check that as much as we can when we're interacting with them. But I think that, it's also really important to be communicating and educating our colleagues. When we see something in the medical record, another example, one of my trans women was seen by ENT, and the history and physical says a feminine-looking male.
Right.
And in the medical record and on her driver's license it says female. And so I think little small things and just like encouraging our colleagues to be like, okay, we can. This is not difficult. Let's just take a time, a second, and really think about who is this person in front of me and how can I best care for them. I mean, I'd love to hear, like how you guys are, or if you guys are employing anything in your clinics and how you're addressing those issues, or maybe it's less of an issue here in New York than it is in California.
No, I think it's an issue everywhere.
Okay.
And, unfortunately, it's difficult to control outside of our medical home, I think, as you illustrated here. So I think it's really, really difficult. You can only do so much to educate your own staff about being, non-judgmental and kind of acknowledging any implicit bias. So just in this case specifically, because I think there's a lot of these issues that are surfacing with her, how did you kind of address or have insight into this? And do you think you were able to kind of overcome some of these issues?
So, so for her specifically, I very honestly said, we know that racism exists in medicine, and we know that Black women have disparate outcomes, but when they have Black providers, that's to some degree washed away. So I acknowledge, like, this is a problem, this is real, this is not something that you're imagining. We talked also about how even with HIV, still today, a lot of people still have stigma and assume, that people with HIV, for example, are using drugs, so they're kind of these general stereotypes. If you're a Black woman and you have HIV, you must be using drugs, or injecting drugs specifically. And so we had that conversation. And I did also tell her, I'm like, I honestly don't know if your experience will be dramatically different going to other places, because this is unfortunately widespread, but I haven't been able to get her back into clinic. We talk on the phone, but I haven't been able to get her back into our system. So we'll see. We're working on that.
Right, yeah. Some of the things that we've also employed just to help sometimes re-engage patients is just kind of the use of peers, or also just, we have this care coordination program that will maybe do home visits or just a little bit more intensive kind of outreach just to kind of meet the patient where they're at.
Yeah, unfortunately, we actually have an amazing program where I am that focuses on the care of women. It's not associated with the healthcare system, so it is a separate program, and it's really more about thriving and overall health. But she has sort of burned some bridges there too. But I'm just going to move on for a couple more things. So, again, just a reminder, when you get into asking her a little bit more about her stomach, she goes on a lot more discussion about a whole bunch of other kind of vague symptoms and other complaints, like she's not being called by her case manager and things of that sort. One of the things, though, that surprised me is because, she's saying she has stomach pain. She was telling me, I'm not eating anything, but she's gaining weight. And so that kind of led me to ask her, I'm like, what is going on? Why are you gaining weight? And she then endorsed that, I can't sleep, and I'm like, not feeling well, so I'm just drinking a lot of alcohol so I can fall asleep. And so that's kind of where just probing a little bit more about, like what's really going on, what's kind of underneath these symptoms, revealed that she was now using quite a bit of alcohol in order to just kind of cope with a lot of these complaints, maybe not even realizing that they're likely then worsening or contributing to a lot of the things that she's experiencing. So my last point is I wanted to talk about the oath syndemic. So a lot of our patients, we as HIV doctors tend to really focus on the HIV. We have an HIV primacy thing. That's our number one thing that we want to take care of. And we talk a lot and we feel comfortable about substance use, particularly as it relates to, are you taking your meds? Are you engaged in care? And are you safe so you're not accidentally overdosing? But I think as our population is aging, she's 67.
Wow.
So she's an older adult.
Yeah.
We need to start talking to them about how their substance use can impact them in other ways. So the OATS stands for opioids, other drugs, aging and alcohol, tobacco, and HIV. And it essentially describes that the interaction of substance use, HIV, and aging within the context of these social disparities of health is really detrimental to our older adults. It contributes to falls and frailty, which are both magnified in our population compared to people without HIV. And ultimately early mortality, hospitalization, and things of that sort. So sometimes coming at this from another way, or being cued into maybe there's some substance use in our older adults, when we start hearing about falls or when we start seeing a decline in their physical function. But yeah, that's kind of what I wanted to talk about today. And we're gonna finish off with her voice as well.
In general, do you feel heard by your healthcare providers?
No.
You feel that you have a voice and a say in decision making?
I feel like I'm invisible. I feel like I've been made to feel like I'm nothing, that that they can just do whatever they want to do to me, and it's okay. And I'm not supposed to say nothing about it. I'm not supposed to feel no kind of way while they sit in their office, collect their check, go home to their families, and not be touched, because it doesn't affect them. It doesn't matter. It's been really hard. It have affected me so bad. I have been to the point of suicide here in my house several times. I have been in such a dark place thinking about the things that have happened to me, the things that I've been through. I have been in such a dark place.
Dr. Huhn, I'd love to hear your thoughts on this case.
Well, when I listened to Dr. Karris's patient, and I think we can all recognize the pain that really comes from structural racism and poverty. We know just beyond the HIV world that these patients within these disparate social determinants of health, they have lower life expectancy overall, not only due to medical conditions, but certainly even environmental and violence related. So importantly, as Dr. Karris has illustrated with patients with fractured healthcare medical mistrust, look, we can do our best. It's not going to be everything, but certainly we do our best when we show our best. And our best is really offering those support systems, the compassion, and really trying to overcome that stigma to actually optimize the patient's overall health.
Yeah, I mean, I think that just kind of, summarizes everything that she's been experiencing. And it's hard, right, to hear that, to see the pain. But I think it's a good reminder for us as healthcare providers that sometimes the small things can make such a big difference in both ways,
Yeah, no, absolutely. Yeah. No, I kind of heard that sadness and that despair and possibly loneliness and social isolation, and how those can be really drivers of, not just mental illness, but also inflammation in our patients living with HIV. And so hopefully she gets the help and the connection that she deserves.
Yeah, I agree. We're working on it.
Okay, I'm sure you are. Best of luck.
Thank you so much for speaking with me about my patient. It's really been a pleasure.
Likewise.